Welcome to Sleep Medicine and Physical Therapy Part 7, Sleep Assessment for Physical Therapy Clinical Practice. Today's topic is Objective Assessment of Sleep. I'm HKMU Physio Chris. Let's start today's topic. In this chapter, we'll present some of the objective examinations of sleep. Like in any area of clinical practice, the history, the analysis, and the physical assessment generally offer most of the essential clues needed to establish which additional instruments would be most useful in the diagnostic assessment process. Unnecessary objective examinations of sleep can help physicians with the sleep disorders diagnosis. The investigation of sleep per se is preferable to be done during the nighttime period or the usual sleep period. Although the prescription of objective examinations of sleep is not within the scope of practice of physio, the understanding of the exams will help in clinical practice and in interdisciplinary work. Today we're going to cover four objective assessments, starting with polysomnography, and then overnight oximetry, multiple sleep latency tests, and the maintenance of wakefulness test. We'll start with polysomnography. The Diagnostic Overnight Polysomnography Examination, PSG, also known as a sleep study, is the main exam for assessment and diagnosis of sleep disorders and must be prescribed by the physician. PSG monitors the sleep stages and cycles to identify if or when our sleep patterns are disrupted and why. Sleep staging and marking of the associated events can be performed by a single and trained PSG technician based on the criteria recommended by the Standard Manual for Staging Sleep and Associated Events at the American Academy of Sleep Medicine. Physical therapists can act as PSG technicians and learn how to read and interpret the exam after attending some courses and being approved an examination of the board for registered polysomnographic technologist. The PSG records multiple physiological variables that are monitored by the EEG, the electroencephalogram, the EOG, the electrocoologram, the ECG, the electrocardiogram, airflow surface electromyogram, snoring, body position, saturation of peripheral oxygen, and heart rate. Sleep staging is based on EEG, EOG, and submental EMG criteria. To detect stage R, in particular, EOG and EMG submental recordings are mandatory for detecting saccadic eye movements and muscle atonia. The nomenclature of EEG electrodes follows the international 10-20 system. Brain activity is measured bilaterally at the frontal central occipital mastoid central midline and frontal polar midline. Eye movements are recorded using electrodes positioned near the eyes, below and above, and at both sides. Chin activity is monitored via one electrode positioned above the inferior edge of the mandible and two electrodes positioned below the inferior edge of the mandible, right and left. There are also EEG, EOG, EMG, and ECG. Polysomnography got quite a few reporting parameters, such as the total recording time, which is the total time spent in bed from lights out to lights on. Non-value varies according to age, chronotype, and circadian preferences. Sleep efficiency. The total sleep time divided by the total time in bed. The non-value is greater than 85%. Sleep latency. The amount of time it takes to go from being fully awake to sleeping. Non-value is less than 30 minutes. Sleep stages. The total time in each stage of sleep, meaning N1, N2, N3, and R, divided by the total sleep time. Periodic limb movement index. Divide the total number of periodic limb movements by sleep time. Apnea hypopnea index represents the number of apnea or hypopnea per hour of sleep. Respiratory disturbance index. The apnea hypopnea index plus hypopnea plus respiratory effort-related arousal. PSG can be performed in any age group, even in newborns. PSG is commonly performed in sleep laboratories, but in some cases it can be performed at home or in a hospital setting. It can include different procedures and setups. In a recent investigation, it has been demonstrated that home sleep monitoring has good correlation with laboratory gold standard PSG, representing a growing trend for diagnosing sleep disturbances in selected patients. Other objective assessments other than the PSG. New research is being performed to improve the accuracy of methods based on pulse oximetry. A good example of this new frontier of knowledge has recently been validated. A wireless pulse oximeter coupled with an internal accelerometer reports data on oxygen desaturation index and sleep movements during the night. The analyzed algorithm shares information of the ODI positively related to moderate and severe obstructive sleep apnea diagnosis. Using the 3% DSAT recommended criteria for hypopnea detection, cutoff of 12 events per hour for ODI, has a sensitivity of 95.1%, specificity 80.2%, and an accuracy of 90.1%, with a good performance considering the positive and negative predictive values. Diagnostic Daytime Multiple Sleep Latency Test, MSLT, is performed to assess the degree of daytime sleepiness as the patient stays in a dark and silent environment. In other words, it measures how quickly a patient falls asleep in a quiet environment during the day. The maintenance of wakefulness test assesses the individual's ability to stay awake for a period of time in a calm environment and without stimulation, and also during the day. It measures wakefulness, showing whether the individual is able to stay awake for a defined period of time, usually beginning 90 to 180 minutes after the patient's usual wake-up time. PSG and sleep logs may be useful before the test protocol in selected cases. Sleep latency is assessed by how long individuals take to fall asleep during the test. The main difference between the multiple sleep latency test and the maintenance of wakefulness test is that the maintenance of wakefulness test is intended to measure the ability to stay awake, while the multiple sleep latency test is used to quantify the ability to fall asleep, although both express results based on the mean values of the sleep latencies. The multiple sleep latency test is used as part of the diagnostic criteria for central disorders of hypersomnolence, especially narcolepsy and idiopathic hypersomnia. On the other hand, the maintenance of wakefulness test can be used to estimate the safety in work environments in which somnolence would be represented in the risk and evaluate the response to treatment in patients with excessive daytime sleepiness. Nevertheless, the somnolence is a multifactorial clinical parameter. The maintenance of wakefulness test results are difficult to interpret, and the predictive value for assessing accident risk is not clear. Contents covered. We've covered polysomnography, as well as the overnight dosimetry, multiple sleep latency tests, and the maintenance of wakefulness tests. That's all for the topic of objective assessment of sleep. I'm Chris, signing out.